Thank you, Evgeny, and good morning, everybody. And this is a very large room for this session. So to the extent that people, especially way over there, if you want to come on towards the center, great, but I understand sometimes I like to sit out on the edge as well. So welcome to this event, to the day. Healthcare is the biggest part of our economy. It's the biggest part of the economy of almost every country in the world, about $7 trillion. Beyond being really big, it's also deeply intimate for every one of us. All of that means that it is an area that has a lot of potential for growth, for improvement. And AI, as it is beginning to change and impact every part of our society, is beginning to have very important effects on health and healthcare. And today's discussion is really about that, and about that intersection and how that's going to play out and how we can shape it. And we have people who are AI experts who are working on health, and we have health experts who are thinking about AI, and really a combination of both sets of folks who will be speaking to you this morning, or actually during the day. And we're going to get kicked off with our first speaker, so I'm not going to go too much longer. Let me just very briefly introduce you to our first keynote, Vivian S.Lee. Vivian is a physician. She is the president of health platforms at Verily. She is a radiologist by training, a member of the National Academy of Medicine, has had a long and distinguished career already at her young age. Among her other many accomplishments was leading the University of Utah health system, really making it one of the nationally prominent health systems, and that was before she went off to Verily. So what she is going to talk to us about is big data, AI, and the journey to value-driven healthcare. And so without further ado, Vivian, thank you for coming.
All right, thank you so much, Ashish. Thanks, Evgeny, for so kindly inviting me to speak, and thanks all of you for staying around to the end of this meeting. Hopefully today will be very worthwhile for you. I am going to, as Ashish alluded to, be one of those people who is coming from the healthcare side and sharing with you some of my perspectives on where I hope the AI community will help to drive us forward and really enable a true disruption in healthcare in this country, and hopefully for the benefit of others around the world. The story that I want to tell you is really about a journey to value-driven care. Maybe before I start, though, let me just get a sense of the audience. How many of you are actually working in a field that is related to healthcare or life sciences? Just curious. And then how many of you are hoping to get into a field that is related to healthcare or life sciences? Okay, so good, terrific, thank you. So I work for a company called Verily Life Sciences. It was formerly known as Google Life Sciences. It is Alphabet's healthcare and life sciences company, and I joined it about 18 months ago. But my career prior to that, as Ashish alluded to, has been in academic medicine. And the story that I want to tell you this morning is really a story that parallels my own career in terms of thinking about the direction of where our healthcare system needs to go. So this story starts in the summer of 2011, right here in Manhattan. At that time, I was the chief scientific officer at NYU Langone Medical Center, responsible for the research portfolio there. And I was particularly interested in, I became very interested in these new fields of population health or implementation science or other areas of health services research, and how those areas could help to improve our healthcare system. In the summer of 2011, I found myself taking a cab to JFK and boarding a plane for the beginning of the next phase of this journey, which was a trip to Salt Lake City, Utah, where, as Ashish said, I was given the privilege of serving as the CEO of the University of Utah Health, the dean of the medical school, and also the senior vice president of the health sciences campus there, which meant being responsible for colleges of pharmacy, nursing, health, and a new dental school. And around that time, as you may remember, the Affordable Care Act was really just taking hold across the country, and it was moving up through the the courts, and its constitutionality was being challenged, as you might remember. It actually still is. But at that time, it was going to the Supreme Court, and there was a lot of speculation about what would happen to healthcare in this country. As you'll remember, the Supreme Court voted just barely to support and uphold the Affordable Care Act, with a couple of key exceptions to that. But even through all the discussions within the healthcare community, everyone was saying the train has already left the station. Regardless of the outcome of the Supreme Court case, we in healthcare knew that healthcare couldn't continue the way it was, that it was really time to move away from fee-for-service to more value-based care. And so people said and wrote, the train has already left the station, we're already on our way. Well, as I landed and got settled in Salt Lake City, leading this healthcare system that was about a $3.5 billion system, so sort of a medium-sized healthcare system, I discovered that actually the train really hadn't left the station. And for the most part, the train was still in the station, mostly across the country. And much of the work that needed to be done to improve our healthcare system really still remained to be taken on. And so that's what I wanted to start with, was just a simple overview of where we are in healthcare and what some of these initial changes are that we're hoping your community will really help us with. So where are we today? I think most of you are familiar with the rising healthcare costs. I don't know if you've seen the data presented in this way, but over the last 50 to 60 years, healthcare costs have increased at a rate that is 50-fold faster than the rate of increase in wages. And another way of saying this is that the rising healthcare costs have impacted everybody in this country, often in invisible ways, whether it's through taxes, or which support, for example, Medicare, Medicaid, and also the employee subsidy, or through your own out-of-pocket payments through rising deductibles, co-payments, co-insurance, or probably most insidiously through invisibly by really flattening wages, through flattened wage growth, because employers are having to take money for wages as well as for retirement benefits and use it to support employee health costs. So this is impacting all of us. And as you may know, that increase in cost is coming without corresponding increases in outcomes. So this is one way in which these kind of data are often shown. You have life expectancy on the y-axis, you have healthcare cost per capita on the x-axis. Typically, the more you spend in a country on healthcare, the better your population is, with the extreme exception of the US. If you want to read more about this in detail, actually Ashish Jha and his colleagues wrote an excellent paper in JAMA a couple of years ago, which I highly recommend. And not only is it not seen in outcomes, it's also not seen in the quality of care and the way in which we deliver care. And this is a slide that shows you the defects per million against the percentage of defects, kind of the Six Sigma scale. And you'll see that while we're aiming for Six Sigma, the only place in which we're near to achieving that is in anesthesia-related fatalities. So if you do undergo anesthesia, you're very likely to survive that. That's good. The bad news is hospital-acquired infections, adverse drug events, even just the regular following of guidelines like not giving antibiotics for common colds, we don't do very well on. Our defects are very, very high. And all of this is coming at the expense of really frustrating our clinicians and our physicians. It may surprise you to hear, given that the quality of life you would expect for physicians to be reasonably high, but study after study is showing that about 50% of all physicians are clinically burnt out. And that's in large part through inefficiencies in our system, our electronic health records, and administrative burdens, among many other factors. So I'll just say, in terms of the context of what I'm going to share with you, I did have the privilege of having a year sabbatical after my 6-year tenure at the University of Utah in order to research more about outstanding organizations across the country and world who were doing really innovative things in healthcare. That actually is culminated in a book that is coming out in May called The Long Fix. And one of the things that I was able to do was to ask over 100 people in healthcare, whether pharmaceutical companies, hospital people, non-for-profit leaders, even journalists, if you could change one thing about healthcare in the US, what would it be? If you could just change one thing. And the vast majority of those said the payment model. That the way in which we're getting paid in healthcare, the way in which we're expecting our goods and services to be delivered in healthcare is so different from all other industries in this country. We are paid fee for service. The more we do to people, the more we get paid, the more we value the service or the good. And it's really not based on the outcome or the impact on health. So let's just talk a little bit about this payment model, and then I will move to some examples that do involve some AI, so don't worry. The current payment model, for the most part in this country, and it's just for the most part, it's not completely, is fee for service. I'm an MRI radiologist, so I embody the revenue center of most hospital systems in a fee for service world, which means the more MRIs you do, the more money the hospital makes. That's the old way, the fee for service model. And what we're realizing is that in order to really change the direction of healthcare, in order to really put the full market force behind improvements in healthcare, we really need to transform to value-based care. And in value-based care, we often talk about the quadruple aim, triple aim or quadruple aim from Don Berwick and the IHI. That includes better outcomes, lower cost, a better clinician experience, and a better patient experience. And if we can start valuing our goods and services and pricing our goods and services, including pharmaceutical drugs, based on their impact on health, then we can really start to improve our overall healthcare system. So let me put this in a little bit more, less wonky policy terms and just more specifically in an example of a patient. So when I showed up in Utah in 2011, as I said, we realized that the train was just beginning to leave the station. And one of the changes that happened over the next year or two when I was there was an evolution that is taking place across the country in the way in which Medicaid is thinking about how they pay for healthcare. So let me tell you about a patient that we had. I call her Mary. That's not her real name, and this is not her real photo. But she is a real person. So we had a patient, and she was a Medicaid patient in Utah. And as the university health system, we took care of many of our Medicaid population patients. And she was a frequent flyer in our emergency room. The previous year, from when I'm talking about, in 2012, Mary came to our emergency room over 50 times in that 1 year. She came in, she had chronic diseases, she had diabetes, she had some asthma, she had a little bit of depression, and she came in more than 50 times. Because up until 2013, Medicaid was paying us in a fee-for-service model. Every time Mary came into our emergency room, we got to bill Medicaid, and we got paid. We got paid for every x-ray, every prescription, every visit to the emergency room. So you can imagine when Mary showed up the 50th time that year, we said, here's Mary. We're going to make some more money. We wish she didn't come, but we weren't very proactive about preventing her from having to come. Well, that changed pretty dramatically in January of 2013 when the state decided to completely change its payment model. And this, as I said, is happening across the country in many different ways. And they changed it to what's called a capitated payment model. And in a capitated payment model, what the state decided to do was they would look at all of the patients on Medicaid who were routinely coming to the university. They decided in advance, they did a risk adjustment to figure out just how sick they were and predicted roughly how much they thought that patient would need in care. So they estimated Mary in the context of the conditions that she had. And then they said, guess what, University of Utah? Next year for Mary, you get $13,000 to keep her healthy and out of the hospital. And you have to meet some quality metrics. You have to keep her healthy. You can't just block your doors to her. But you would only get a fixed amount of money. So imagine us as a university health system trying to subsidize our researchers, trying to subsidize our students, trying not to go bankrupt on the clinical side, thinking about all of a sudden how we were going to care for people like Mary. So in this value-based care world, what we call a value-based care world with this kind of a payment model, all of a sudden we started looking very carefully at all of our Medicaid patients to try to anticipate who were the frequent flyers and who we really needed to intervene on early. For the first time, we matched Mary with a primary care physician. She didn't have one, so we matched her up with one and said, really stop using our emergency room as your own clinic. Let's get you into a PCP, a primary care provider. And we even assigned her a care manager to help remind her about the appointments, to help deal with transportation issues when she had trouble getting to the clinics or getting her prescriptions filled. And we just really worked very closely with Mary to try to keep her on track and to keep her healthy and out of the system. I hope you appreciate with this system, with this change, why payment models are so critical for how we think about healthcare. Now, if you take a step back and think, well, how is this relevant to potential any work that might be done in the AI or big data community, you can think about it at a more macro level, which is we really want to keep the population healthy. Are there public health prevention strategies that we can use? Are there ways in which we can work with communities, cities, and states to address social services? Are there ways in which we can more effectively look at the data that we have and predict who we need to intervene on earlier, who we need to provide more consistent, for example, transportation resources, food resources, and so on to keep them out of our clinics and hospitals? For patients who are reasonably healthy, mostly out of the hospital, but who have some chronic conditions like diabetes or asthma, how do we help them stay healthy and keep them out of the hospitals? What tools can we develop to provide that support? And then if the patient does have to come into the hospital where the most expensive care does take place, how can we ensure better outcomes, safer, more consistent care? How do we get closer to Six Sigma care and lower the cost of care? So in that context, I'm going to talk about 3 examples from Verily. I just share these examples because they're the ones I know best. But of course, across the industry of health and technology, there are many, many efforts that are undergoing. And as I share them with you, and as you consider your own work, I will just emphasize what I say to our own team of engineers, which is that we consistently evaluate the work based on not fee-for-service model, but on a value-based model, which is for all of our innovations, are we really driving quality and outcomes? Are we improving the experience of care for patients and physicians? And are we reducing the cost of care? So I'm going to take you through 3 examples that I hope fit into a little bit of this structure. I'm going to start with how do we keep people like Mary out of the hospital, out of the clinic, and healthy as much as possible. And the example I'm going to give you is a joint venture between Verily and Sanofi, a company called Onduo, which was established about 2.5 years ago now to look at type 2 diabetes. So type 2 diabetes, as you know, is one of the largest public health concerns in the world and only rising in prevalence, thanks to generous exportation of American habits, I have to say. And I'll tell you a little bit about the story. This could be Mary, but in this case, this is another patient. This is a patient whose real name is Steve, and he's been very open about his condition. He is an individual who lives in Marietta, Georgia. He was pre-diabetic for many years, and then one day he came into the emergency room feeling nauseated, vomiting, and his blood sugar was in the 400 range, which is way too high, and he was diagnosed with no longer being pre-diabetic, but with having type 2 diabetes. For about a year, he tried to manage his own blood sugars. He did the finger sticks, tested his blood sugar, tried to control his diet, and really struggled. And so at the end of about a year, his Blue Cross Blue Shield plan, his health insurance plan, recommended that he sign up for our initial pilot study with Onduo, which is a virtual diabetes clinic. And the idea behind Onduo is really this concept of co-producing health. The idea is how do we use technologies to help people like Steve really manage his own health, mostly outside of the walls of the clinics and the hospitals. So it's a virtual coaching platform that has a connected sensor and provides some AI-driven insights that enable the patient and caregivers as well as the clinicians to really manage their disease and, most importantly, drive behavior change. So the key components of it are shown here. There's a continuous glucose monitor. So this is a device that you can put on your arm or on your abdomen. There are multiple manufacturers. The one I'm showing you happens to be one that we build for Dexcom. And this technology enables you now to no longer have to stick your fingers, but it has a Bluetooth chip in it, and so it can transmit your blood sugars 24/7, because it's a continuous glucose monitor, to the app. With the app, you have the ability to follow your blood sugars and make an association between your blood sugars and your diet, as well as connect with a coach. And the goal is to enable you to keep your blood sugars under control as a diabetic in order to prevent subsequent complications. So some of the features of it, I think, that maybe illustrate where we're using some of the AI include the ability to automatically identify foods and meals and snacks. So typically for diabetics, you're asked to keep a food log. I'll tell you, my sister's an endocrinologist at Stanford, and she tells me all the time that patients really never keep this food log. It's not surprising. But with this app, you take pictures of your meals and snacks, and we use some code from Google to automatically recognize over 1 million different kinds of foods. And that's a point of engagement, I think, with many patients. Many people just find it fun to go to their favorite ethnic restaurant and take a picture of it and see if it recognizes their pad thai or whatever their new food is. But it does enable them to make this visual association so that they can see with their blood sugar tracing, which is the middle part of the drawing there, what each of those food items, like this McMuffin or whatever exactly this is, and how it's affected their breakfast blood sugars. And with the algorithms that we have, we can actually derive some personalized insights for each individual patient, because everybody reacts to meals differently. That may not surprise you. If we all ate a banana in this room, we would have different blood sugar reactions. And so the algorithms that we are developing and refining all the time enable us to translate those into some insights for the patients and maybe even some recommendations. So we notice every Wednesday you love to have that egg muffin thing. Maybe just try taking the top half of the muffin off next time, because we think that'll do a little bit better for your blood sugars, for example. I think the most meaningful part of this kind of engagement is still the personal touch. So I will say that as much as I think AI-driven virtual bots and so on have a lot of promise, there is nothing that replaces the human touch, in my view. And so we do have the ability to chat and video conference with coaches and with physicians, although increasingly some of the interactions are with a bot as opposed to the real person. But we mix those up. And for the clinician, I think very importantly, again, some of the insights that we're able to derive for each patient are shared with the coaches so that they can make some of these recommendations directly to the patients. And the results of our work and others on the market. So again, I'm not intending to say that we're the only ones that can do this, but this model of having sensors and AI-driven algorithms that can derive insights is very, very powerful. And as a clinician, I will say that I really, really welcome the continued development of these kind of technologies. So this is a chart from a recent publication showing that for patients who have elevated blood sugars, who have not been able to maintain their blood sugars, that's the furthest right on this slide, we see significant reductions in HbA1c, which indicates much better blood sugar control in very short periods of time with this kind of technology. Patients with diabetes have a number of other complications, and just another illustration of AI, a really very powerful application of AI, is in screening for diabetic retinopathy. It's a common complication, and early intervention can prevent blindness in type 2 diabetics and type 1 diabetics. And so this was work that was done by colleagues in Google Health, in what used to be Google Brain. And here, looking at the retinal images, these are photos taken from the back of the eye, using, again, large, vast data sets, really deep learning algorithms, sophisticated deep learning algorithms to identify the abnormalities automatically. This is critical because we do not have enough ophthalmologists in the US, much less the world, to interpret all of these scans. And the results were very impressive. This is from a publication in JAMA from about 1.5 years ago. It's now been deployed in a number of countries, including India. One of the things that I will say about this is I feel like the potential for AI with the evaluation of imaging, whether it's retinal images or my own field, radiology images like MRI, mammography, chest CT scans, and so on, is the potential is really beyond just simply replacing or improving what a human can do. And one example of that is in this work that was also done in a collaboration between Google Health and Verily, which was to look at these retinal images and try to examine whether there are further insights that we can get from these images beyond just looking at the health of the eye. And so this paper was published in Nature Biomedical Engineering that showed that the retinal images not only predicted eye health, but it actually predicted cardiovascular risk factors, cardiovascular mortality or morbidity, and even hypertension. And it's not surprising for those of us who are in healthcare or in medicine, because the back of the eye, you're just looking at the blood vessels at the back of the eye, so it's a window into your cardiovascular system. But it certainly does make me wonder, having been a radiologist and having read, I don't know, thousands of chest x-rays, what information is hiding in these films, and what insights can we have to not only predict health, but also to predict decline and be able to intervene. So that's a challenge I hope that many of you are thinking about. A second example that I want to share with you is in the broader space of clinical discovery. And this is a project called Project Baseline. It was the core project at Verily when we first got started about 5 years ago. The question is, in conditions like diabetes, where I just showed you, we know that blood sugar and then HbA1c, this other assay, they are very good markers for disease and disease control and risk of complications. But what about other conditions where we don't have such good biomarkers? So this Project Baseline was started as the brainchild of Rob Califf, who is a lifelong clinical trialist, who was most recently the FDA commissioner, and he now works for Verily and Google, and Andy Conrad, our CEO. And about 4 or 5 years ago, they got together and said, what if we collected every possible bit of data about a human being and then followed them for, say, 10 years to see if we could identify other biomarkers, other predictors of disease. And so that's what they did. It's literally terabytes of health data from thousands of volunteers. Includes everything from whole body sequencing, all kinds of omics, including fecal microbiome, to sensor data, sleep data, EHR data, claims data. I mean, you name it. We are collecting every possible bit of data. And the objective of it is to identify these new markers, but what it's enabled us to do along the way is to have the capability of integrating data, just a wide array of very disparate kinds of data, and to develop actually some tools and technologies for just simply acquiring and organizing them, as well as analyzing them. And as we were going down this path, and we are continuing with this study, this is in close partnership with Stanford and Duke, we realized that the ability to collect these disparate sources of data from individuals and analyze and organize them effectively was actually very valuable in the field of clinical trials and clinical discovery. And one of the reasons why, for example, pharmaceuticals are so expensive is because of the very high cost of running these drugs through trials and going through FDA approval. So the clinical trials system is a broken system. Most trials do not recruit all the patients that they need to recruit. They're very expensive, they're very labor intensive, and they're very costly. And also, the people who participate in these trials don't necessarily reflect the populations. So in this slide, you'll see the white areas are where all these trials take place, and the red areas are where we have the people who are probably in most need of healthcare and medical advances, and there's just not a lot of overlap between the two. So by creating, through Project Baseline, a large data registry where we invite and welcome patients, some who provide terabytes of data, others who have a lighter participation, to be a part of this registry, it enables us to connect organizations that are running these clinical trials, companies, with patients who are from all over the country and in the future all over the world. And we hope that this will enable faster and more equitable drug discovery and clinical research, as well as identifying new biomarkers for us to develop additional tools like Onduo. Very quickly, I'll just finish with one last example. Now, this is sort of just for fun. So this is now about machine learning and AI in public health, and this is a project which I think has the best name ever. It's called Debug, and you'll see why in a second. It was the idea of one of our leaders in Verily who has a passion for this. And this is really trying to address the problem of mosquito-borne illnesses. So this is now public health, like global public health that we're talking about. In particular, the mosquito that carries yellow fever, dengue, chikungunya, Zika, and that is this mosquito called Aedes aegypti. And this individual in Verily who decided to take on this project really wanted to help eradicate these diseases and focused on these mosquitoes. Now, let me tell you a little bit about mosquitoes. You probably didn't come to this session expecting to learn about mosquitoes, but I'm going to tell you a little bit about mosquitoes. So, Aedes aegypti, when they are infected with a bacteria called Wolbachia, the sterile males essentially breed with the females and the eggs never hatch. Now, Wolbachia is a bacteria, I imagine none of you have probably heard about Wolbachia, but Wolbachia is prevalent in insects and animals. It's about 60% of all animals and insects carry Wolbachia. It's not, humans don't, and for whatever reason, Aedes aegypti don't, but it's very, very common. And so this was our strategy. We didn't invent this, I'm just going to say, but this is the strategy we decided to adopt in order to try to tackle these infectious diseases. Now, the challenge is that we need to, so one other fact is that only female mosquitoes bite, males don't. So our goal was to release as many males with Wolbachia as possible without releasing any females, because we didn't really want to increase the burden of biting mosquitoes in any community. So the challenge here was to enable these mosquitoes to mate and then to separate them, the males from the females. So here is our larval rearing robotic facility in South San Francisco. And here's the AI piece, which is to differentiate the males from the females. They have different bodies. Because I'm a radiologist, I'm really good at spotting those differences, but I highlighted them for you. Okay, that's a joke. Okay. Anyway, so we developed the algorithms to do that, and we've been piloting it in Fresno, California for a couple of years now. We've gone through 2 seasons. And here's an example of the results. So in red, it's the neighborhoods around where we released, and then in blue, it's the areas where we released this. People do ask me, did you tell anybody you were doing this? Yes. The folks in Fresno, California, they know this was actually, has been reviewed by many governmental agencies. And we are in partnership with folks in Australia and Singapore and other countries around the world. So that's an example of where I think there's a lot of potential in ways maybe that are unexpected. So just to wrap up, I think the potential for the work that you do in impacting care, especially in driving value, is absolutely enormous. I know people like to say never waste a crisis. In healthcare, we're in a crisis now. And so there's an enormous opportunity for change. And in that change, I really hope it'll be an AI-driven change. So thank you very much for your attention. Happy to take questions, right? Happy to take questions. Yeah. 5 to 10 minutes of questions.
Hey, thanks for that great talk.
Thanks.
Just thinking back to that sort of embarrassing scatter plot of sort of healthcare spending versus healthcare quality in different countries. So I guess the sort of hypothesis is that the main thing that differentiates the US from those other countries is the fee-for-service payment model. But I'm wondering, it seems like sort of value-based care might also be a pretty new payment model as far as sort of different countries go, and I'm just wondering, isn't it sort of like an uncontrolled experiment? Like, why not do something closer to what other countries do in terms of payment models?
Yeah, it's not the only thing that's different. So of course, the biggest differences are we don't have universal coverage, we have a private insurance model. It's difficult to say, you know, it would be wonderful if we could wave our magic wands and we could all of a sudden say we're going to just completely blow up our healthcare system and become some combination of Northern European, Canadian, New Zealand, you know. That would be wonderful. I think what we're really talking about now is, given where we are now with 18% of the US economy firmly embedded in the current model, what changes can we really push for that are likely to be effective enough to drive the improvements that we need to see? And that's where changing the payment model is probably the most effective lever that we have.
Thanks.
Okay.
Thank you for a really, I'm over here. For a really interesting talk. I have actually 2 questions, so I'll try to go fast. With respect to the value-based model, that's really compelling at the hospital organizational level, but I'm curious if you drive it down to the level of the PCPs themselves, what's the incentive for a PCP to take on a really complex patient whose outcomes are likely to be really bad? And it's kind of related to that. You talked about patients like that really needing a community-wide health care, and yet the tool you showed for diabetes was for an individual. So are you at Verily working on tools that actually take into account that patients with complex conditions actually have many, many caregivers and physicians?
That's a really fantastic question. And in fact, one of the concerns that people have, and we all share, is that when we move to the kinds of payment models that we're talking about, that we might put more complicated patients at risk and people might not want to care for them. So where that plays out is really in this process of risk adjustment, which is frankly, if I were thinking about one area where the AI big data community could really help us, is in thinking about risk adjustment. So that's really looking at a patient and figuring out, for example, in Mary's case, maybe we should have gotten paid $18,000 a year for her, and then somebody a little healthier, maybe $6,000, for example, or $200 if they're really healthy. There is risk adjustment, or risk, that kind of adjustment right now in government models as well as in private insurer models. How effective how good they are, I think they could always be better, because the data often, for example, they're based on medical claims, so just how much did you use the healthcare system before. They don't necessarily have that much information about your access and your access to food, to exercise, to whether you're actually receiving good healthcare in an environment that supports that. So I think maybe that's the answer to how we avoid that. And then how are PCPs thinking about it? Well, one model that's actually moving around the country is a Medicare Advantage model. So for patients over 65, the physicians that are caring for them, increasingly there is a version of Medicare Advantage where Medicare, so the government, is paying physician groups a fixed amount that's risk adjusted for caring for those patients. And actually the payment so far is quite generous. Ashish can tell you even more about it, about just how maybe overly generous sometimes they are. But those are really intended to enable PCPs to take the time to really invest in complicated elderly patients to try to keep them healthy and outside of the hospital. So there is hope.
And the tools for care by many people?
The tools,
if you're working on that?
Yeah, so I think the tools that I tried to show you were really more about how we really empower patients. I think there are tools that are very important for the clinicians, for the community, for the people who are paying, and we are looking at all of those.
Hi, thank you for the talk. I see the Onduo for diabetes from the Apple Store and immediately start to download it. That's a great thing. So one question is, can you talk a little bit more about how your team built this app, how the sensor and AI come together, and how the clinical researchers recognize and realize this one is working, not only for patients, and that this also help for the prevention work? Like the healthy people can use this one, check what they eat, how many sugar they eat to use for prevention. Thank you.
Okay, so I think I started with the disclaimer that I'm a physician, and I work very closely with our AI, with our engineers, but I really probably can't tell you specifically I probably wouldn't even be allowed if I could, how those algorithms work. So, but just in terms of the general way in which we use them, examples that I tried to show included the algorithms to recognize the meals and snacks. That's completely an AI-driven algorithm. Ways in which we identify patterns between a person's meals, or the ways in which they're eating and exercising, and how their blood sugars are changing. We actually are using AI in order to find those associations. And also using it, well, actually we're kind of using it really wherever we have enough data in order to derive some more insights.
We're close to running out of time.
Okay, close to running out of time.
Take a couple of questions.
Quick questions.
All right. Do you?
We'll just let you
And
answer
then,
them all.
okay.
It's over there.
All right. Have you done any investigations into adapting Onduo for type 1 diabetes?
So there's a lot of different disciplines here today, and I was wondering, what are some of the other things that healthcare leaders mentioned besides the changing the value model?
I was wondering about the.
And then we'll click.
I was wondering about the food identification, and I think it would only work well for standardized foods like fast food, where you know the food content. But if I give a blurry picture of something, you might really recognize the food, but you won't know how much sugar there is, how much starch
That's
there
right.
is, and so forth.
Yeah, that's true. Yeah. Okay. So we are very interested in type 1 diabetes. It's when we started, we really needed larger populations, and we started with type 2. But there's absolutely no reason why this can't work for type 1. It's just not. We haven't gone through the FDA process yet. The meals and snacks, you're right, it doesn't tell you how much the person consumed. It's really a recognition of the food. I think it's more, in my mind, it's more of a point of engagement for the patient even than actually being used to guide their diets. But we can predict, for example, the effect of the carb load of the meal. If you ate the whole thing, this is what the carb load would be. And millions of people are using this app for other purposes, so they're not just using it in Onduo, so there's pretty wide recognition for that. And for millions of different meals, it's not just from our patients who are using it. And then what did other people say other than payment? So payment model was about 2/3 of the answers, and other answers include really needed to focus a lot on social determinants of health, because we realize now as we try to keep people out of the hospital that really it's a lot more about what you eat, whether you smoke, whether you exercise, what you inhale or drink, that affects your overall health than it is what happens once you get into the healthcare system. So people are worried a lot about that, really want to invest a lot more in social services in this country than in healthcare, because spending it on healthcare is too late. People are also very worried about equity, widening gaps between the well and healthy. I'll tell you, when I give this talk in front of my colleagues at Verily, we have great health benefits, but we don't recognize that about 10% of Americans still have no insurance, and a rising percentage of people can't afford their copays and are underinsured. So that widening gap, I think those are a couple of other areas. So thanks. Thank you very much.